The oculomotor nerve. Oculomotor nerve is entirely motor nerve. The motor nerves are 3, 4, 6, 12, and 11. Pure sensory are 1, 2, and 8. It supplies all the extraocular muscles except the lateral rectus and the superior oblique. Lateral rectus by the sixth nerve and superior oblique by the fourth nerve. It also supplies the intraocular muscles, sphincter pupillae, and ciliary muscle by the Edinger-Westphal nucleus. Functional components are the general somatic efferent component, which is concerned with the movements of the eyeball. So this is the general somatic efferent, and the general visceral efferent, which is the parasympathetic component of the nerve, which supplies the sphincter pupillae and the ciliaris muscle and is meant for accommodation and constriction of the pupil. So the collection of the cell bodies inside the CNS is nucleus and outside the CNS is ganglion. And the collection of the axons inside the CNS is tract and outside the CNS is nerve. Oculomotor nucleus complex is situated in the midbrain at the level of this. There is superior colliculus in the ventromedial part of the central gray matter that surrounds the cerebral aqueduct. It is a longitudinal column of about 10 mm in length. It extends above to the level of the floor of the third ventricle, and below it is related to this nucleus of the trochlear nerve. Now, the components of oculomotor nucleus complex are two motor nuclei, main motor nucleus of large multipolar neurons, and accessory parasympathetic nucleus, which is the Edinger-Westphal nucleus of small multipolar neurons. The main motor nucleus of the third nerve is composed of the subnuclei supplying the individual extraocular muscles. So there are 5 main motor subnuclei according to the concept of Warwick. So this purple one, this is the dorsolateral nucleus, which is for ipsilateral inferior rectus. Then there is one ipsilateral nucleus, which is for inferior oblique, this green one. Ventromedian nucleus for ipsilateral medial rectus, this yellow, and paramedian, which is for contralateral superior rectus, this blue one, and this one central caudal nucleus, which is for bilateral LPS. So all the muscles will have ipsilateral supply except the superior rectus, which will have contralateral supply. Now, the accessory motor nuclei, which is the Edinger-Westphal nucleus, which is situated posterior to the main oculomotor nerve nucleus. It sends the preganglionic parasympathetic fibers along the other oculomotor nerves. It consists of a median and two lateral components, and the cranial half of the nucleus is concerned with light reflexes and the caudal half with accommodation. And the median part is fork-shaped, which is known as nucleus of Purlia, and its role in convergence is questionable. Now we already saw the that only superior rectus have contralateral oculomotor nucleus, so it has crossed fibers. All other have uncrossed fibers, and LPS has both the crossed and the uncrossed fibers. And ipsilateral Edinger-Westphal also has uncrossed fibers, which goes to the constrictor pupillae and the ciliary muscle. Now, the connections of the nucleus is the oculomotor nucleus is connected with the following: the cerebral cortex, the motor cortex, precentral gyrus of both the sides through the corticonuclear tracts, which is the pyramidal tracts, visual cortex through the superior colliculus and the tectobulbar tract, and the frontal eye field. Now, the nucleus of the fourth, sixth, and eighth cranial nerves through the median longitudinal bundle, pretectal nucleus of both the sides for light reflex, vertical and horizontal gaze centers through the median longitudinal bundle, and cerebellum through the vestibular nuclei. Now, the motor area of the cerebral cortex projects to the cranial nerve nuclei through corticonuclear fibers. So when the gaze is shifted from one object to the other, the eye undergoes movements called saccades, and the controlling center determine the velocity and extent. And for when the eyes follow a moving object, then a different kind of control is required, which is the pursuit movement. So what were the areas that were projecting to the superior colliculus? One is motor area, area number 4. One is prefrontal cortex, area number 6, 8, 9, 10, 11, and 12. Frontal eye field, area number 8. And one is the supplemental eye field located on the medial surface of the hemisphere, which is area number 6. So this is motor association of premotor area. And one is the posterior eye field in the parietal lobe. Now these all the areas of the cerebral cortex, they pass through to the superior colliculus and some via the basal nuclei. And the superior colliculus is also receiving fibers from the retina, from the pretectal nucleus, and from the cerebellum. Now this superior colliculus is receiving all these fibers, and it will project to the vertical gaze center in the midbrain and to the horizontal gaze center in the pons. So it projects to the vertical gaze center, which is in the midbrain, and it is located in the rostral interstitial nucleus, which is a collection of neurons within the medial longitudinal fasciculus and in the interstitial nucleus of Cajal. This center controls the vertical eye movements, and the horizontal gaze movement center lies in the pons in the paramedian reticular formation, and it controls the horizontal eye movements. In addition to the efferents from the superior colliculus, these centers also receive some direct cortical fibers and some fibers from the cerebellum. Now, these efferent from the vertical and the horizontal gaze centers project to the third, fourth, and the sixth nerve nuclei, and the cranial nerve receive all these efferents. So, whatever they were receiving, third, fourth, and sixth nerve are receiving corticonuclear fibers, fibers from the vertical and horizontal gaze centers, direct fibers from the superior colliculus and from the pretextal nuclei, fibers from the vestibular nuclei, which travel through the medial longitudinal fasciculus, which provide information about movements of the head and neck from the vestibular apparatus. Through the vestibular nuclei, the oculomotor nerve, trochlear, and the sixth nerve, the third, fourth, and sixth nerve are brought under cerebellar control. The final control of vertical gaze is fibers passing from the third and the fourth nerve. And the final control of horizontal gaze is mainly by the sixth nerve, which is in the pons. So horizontal gaze center was in pons, and sixth nerve also rise from the pons. So that controls the horizontal gaze center, the abducent nerve. Now, if we have if we want to look towards the left side, so the lateral rectus of this side and the medial rectus of this side will fire, and the PPRF supplies the abducent nucleus of the same side. PPRF and MLF. So PPRF is a longer word, so that supplies the sixth nerve, which is bigger letter, and the MLF supplies the third nerve. MLF has three letters. Third nerve, it supplies the third nerve. And if you want to look towards the left side, the PPRF supplies the sixth nerve of the same side and the contralateral MLF. So now right eye, if PPRF and MLF both is gone, so PPRF means ipsilateral lateral rectus gone, and MLF of the contralateral side. So left side MLF gone means third nerve gone means medial rectus gone. That means adduction deficit. And right eye MLF also there. Right eye third nerve gone. Right eye medial rectus gone. So right eye adduction deficit. So in the same eye we'll have abduction and adduction deficit both. And in the contralateral eye we'll have only adduction deficit. And the contralateral side there will be abduction nystagmus. So that is 1.5 syndrome. Course of and distributions. Course can be divided into the fascicular part, the basilar part. So it passes through the ventral aspect of the midbrain and all the nerve fibers from the fasciculus, and they join and leave the midbrain through this ventral aspect. So this is the fascicular part. Then it passes in between the posterior cerebral above and superior cerebellar below. So this is the basilar part. Then it passes in through the lateral aspect of the cavernous sinus, which is the intracavernous part, and then it divides into superior and inferior division and passes through the superior orbital fissure, which is the intraorbital part. So in intraorbital part, there is it is dividing into superior and inferior division. So there can be segmental lesions also, because only one division can also be affected. Now the fascicular part, which consists of the efferent fibers which pass from the third nerve nucleus through this third nerve nucleus is green one, and this passes through the red nucleus, and the medial aspect of this is cerebral peduncle and passes through this medial aspect of the cerebral peduncle. Then they then emerge from this midbrain and pass into this intrapeduncular fossa. Now, the basilar part starts as a series of 15 to 20 rootlets in the intrapeduncular fossa, which join to form a large medial and a small lateral root, and they form the main trunk. So it was passing and it forms the main trunk, and then the nerve then passes between the superior cerebellar artery and the posterior cerebral artery, and they run parallel with this posterior communicating artery to reach this cavernous sinus. So they then travel with the posterior communicating artery to reach the cavernous sinus. Now the intracavernous part, it enters the cavernous sinus by piercing the dura just lateral to the posterior clinoid process. Within the cavernous sinus, it runs in the lateral wall, this above the trochlear nerve, so third, fourth, and fifth nerve, V1 and V2. divisions of fifth nerve, first and second division, and in the anterior part it divides into superior and inferior branches, which enters the orbit through the orbital fissure within the annulus of Zinn. This is the annulus of Zinn, and in this fissure, the nasociliary nerve is lying between the superior and inferior branches of the oculomotor nerve, and the abducent nerve is lying inferolateral to them. In the intraorbital part, in the orbit, the smaller superior division, this is a smaller superior division. It ascends on the lateral side. This is the optic nerve. So it ascends on the lateral side of the optic nerve and supplies the superior rectus and the LPS muscle. And the larger inferior division divides into three branches. Nerve to this medial rectus, which passes inferior to this optic nerve. Nerve to the inferior rectus passes downwards and enters the muscles on its upper aspect. And this is the nerve to inferior oblique, which is the longest of the three branches, which passes between the inferior rectus and the lateral rectus and supplies this inferior oblique from its posterior border. It gives off the motor route to the ciliary ganglion. Now, the ciliary ganglion is a peripheral parasympathetic ganglion which is placed in the course of the oculomotor nerve. It lies near the apex of the orbit between the optic nerve and the tendon of the lateral rectus muscle, approximately 1 centimeter in front of the annulus of Zinn on the lateral side of the ophthalmic artery. Now, the roots of the ciliary ganglion, sensory root, which comes from this nasociliary nerve. So this is the sensory root. These fibers do not relay in the ciliary ganglion and they pass along the short ciliary nerves to supply the ciliary body, iris, and cornea. One is the parasympathetic root, which arises from the nerve to the inferior oblique. It contains the preganglionic fibers that begin, they're coming from the Edinger-Westphal nucleus, then they relay in the ciliary ganglion, and then the postganglionic fibers from this ganglion pass through the short ciliary nerves and supply the sphincter pupillae and the ciliary muscle. Now, the sympathetic root is a branch from the internal carotid plexus. This is plexus around this internal carotid. It contains postganglionic fibers arising in the superior cervical ganglion. These fibers do not relay in the ciliary ganglion. They pass out of the ganglion in the short ciliary nerves and supply the blood vessels of the eyeball. And they supply the dilator pupillary muscle through the long ciliary nerve. The branches of the ciliary ganglion are, the ganglion is dividing into 8 to 10 branches, which divide into 15 to 20 short ciliary nerves, which contain fibers from all the three roots of the ganglion. Now, the causes of isolated third nerve palsy. In 25% of the cases, the cause is idiopathic. And in vascular diseases, diabetes and hypertension, the most common medical causes of pupils bearing isolated third nerve palsy. Trauma is also an important cause. Head trauma causing the uncal herniation, which then impinge on the third nerve, cause the pupil dilatation, which we also call the Hutchinson's pupil, and the aneurysms at the junction of the posterior communicating artery with the internal carotid artery are important causes of painful third nerve palsy. And other causes are migraine. Other rare causes are tumors, vasculitis, collagen disorders, syphilis, and TB. So these are the general somatomotor fibers which are in the middle part. These are the general visceral, which is the parasympathetic. So these are the pupillary fibers peripherally. Vasa nervosum is a micro vessel which is means it is a supply of the nerves. So it is so in microangiopathies like diabetes and hypertension, this micro vessel will be affected. So that will affect only the central fibers and will spare the peripheral fibers. Now the clinical features are there will be ptosis due to paralysis of the LPS muscle, deviation, eyeball is turned down, out, and slightly intorted due to unopposed action of the lateral rectus and the superior oblique muscles. So only lateral rectus and superior oblique was working. So lateral rectus will cause it. Uh, um, Lateral rectus will cause its outward movement, and superior oblique will turn it down and slightly intorted. And these all the muscles are affected. So adduction, elevation, depression, and extorsion will be affected. Now the pupil is fixed and dilated because of the sphincter pupillae muscle paralysis. Accommodation is completely lost due to paralysis of the ciliary muscle. Diplopia is there in all the gazes, and it occurs due to paralytic divergent squint. And head posture, head is turned on the opposite side, tilted towards the same side, and chin is slightly raised because the SR is gone. Only LR is only SR is gone, so chin will be slightly raised to see upwards. and the third nerve is gone. So the efferent, third nerve is the efferent. So third nerve is gone means the efferent that it is not able to take it back. So there will be direct and consensual. Both the reflexes will be absent in it. Features and causes of third nerve lesions at various levels. First, we'll look at the supranuclear lesions. And lesions of the cerebral cortex and the supranuclear pathway produce conjugate paresis. In supranuclear lesions, position and movement of the eyes are abnormal. They maintain the relative coordination and produce no diplopia. So in Parinod syndrome, which is the dorsal midbrain syndrome, there will be impaired upward gaze because tectum is affected and tectum regulates the upward gaze. There will be nystagmus as the inhibitory neurons are affected, and inhibitory neurons to all the muscles and also to the LPS are affected. So there will be lid retraction as there is no inhibition of LPS. So LPS will act more. There will be lid retraction, and all the other muscles will also act more. So there will be nystagmus, and there will be damage to the vertical gaze center as they are close to the superior colliculus, so vulnerable to compression. And there will be lid retraction, so there will be Collier sign, and accommodation is intact because the accommodation fibers are more ventral in the midbrain, and this is a dorsal midbrain syndrome. So accommodation will be impact, but the pupillary light reaction will be impaired. Now the nuclear lesions, there will be bilateral ptosis since single LPS supply both the LPS. So if there is unilateral third nerve palsy, it rules out a nuclear lesion. Common causes are vascular diseases, demyelination, primary tumors, and metastasis. Lesions involving the entire nucleus cause an ipsilateral third nerve palsy. This leads to ipsilateral sparing and contralateral weakness of elevation, contralateral superior rectus, and ipsilateral all the rest other. So lesions involving medial rectus subnuclei, just paired if medial rectus gone. So the patient only LR will work. So there will be wall-eyed bilateral internuclear ophthalmoplegia, which is where we know. Now the fascicular lesions, which is Benedict syndrome. So red nucleus supplies the contralateral distal limb flexor. So the weakness of wrist flexors will be also there. The flapping tremors due to reverse-spinal pathway. So ipsilateral third nerve palsy is associated with tremors and jerky movements of the contralateral side. It occurs due to lesions at the intermediate level of the midbrain, and there will be right lemniscal tract is gone. For example, right side oculomotor nerve gone. So there will be diplopia and ptosis. Also, the right lemniscal tract will be gone. So contralateral sensory changes to vibration and proprioception, which is by the dorsal column or the posterior column. And contralateral ataxia due to right nucleus involvement and right pyramidal motor tract. So there will be contralateral hemiparesis. So this is the pyramidal motor tract, which is the corticospinal tract. So there will be contralateral hemiparesis. Now the Weber syndrome. In this, the fascicular part of the nerve is involved while passing through the cerebral peduncle. Fascicular part is gone. So there will be ipsilateral third nerve also, third nerve is passing through it, and contralateral hemiplegia due to the right pyramidal motor tract involvement, which is the corticospinal tract. And North-Naegel syndrome, which is at the level of superior cerebellar peduncle. So there will be unilateral, bilateral oculomotor nerve paralysis and ipsilateral cerebellar ataxia. These are due to lesion within the midbrain tectum involving the quadrigeminal fluid. Then there will be clot syndrome. In this, there is ipsilateral oculomotor nerve palsy and contralateral hemiparesis. So, clot syndrome is a combination of both the North-Naegel and Benedict syndrome. It affects the oculomotor nerve, red nucleus, and the superior cerebellar peduncle. So, there will be contralateral ataxia due to involvement of red nucleus, ipsilateral ataxia due to involvement of the superior cerebellar peduncle, and the third nerve vesicle. So all the lesions are summarized in this table. Benedict syndrome, site involved is the red nucleus. There will be contralateral tremor, hemichuria, hemiepitosis, or hemibelismus. Weber syndrome, cerebral peduncle is affected. Contralateral hemiparesis or hemiplegia. North-Naegel syndrome, superior cerebellar peduncle is formed. Ipsilateral cerebellar ataxia and clot syndrome is a combination of both the Benedict's and the North-Naegel syndrome, so red nucleus and superior cerebellar peduncle forms a contralateral tremor and ipsilateral cerebral ataxia. Now the lesions involving the basilar part of the nerve. Aneurysms and the posterior communicating artery they cause isolated third nerve palsy with involvement of the pupil because it is a surgical cause, so it will involve the pupil. Now, the extradural hematoma, which may cause tentorial pressure cone with downward herniation of the temporal lobe. This compresses the third nerve as it passes over the stentorial edge. Initially, there occurs fixed dilated pupil, which is followed by a total third nerve palsy. The diabetes cause isolated third nerve palsy with sparing of the pupillary reflexes. Now, the lesions involving the intracavernous part of the nerve. Because of its close proximity to other cranial nerves, intracavernous third nerve palsies are usually associated with involvement of the fourth and sixth nerves and the first division of the trigeminal nerve. Pupil is paired. Sometimes pupil may be constricted owing to the involvement of sympathetics, diabetes, pituitary apoplexy, intracavernous lesions, aneurysms, meningiomas, and carotid cavernous fistula. Now, the lesions of the intraorbital part. So, in the intraorbital part, it was dividing into the superior and inferior division. So, that may cause a segmental involvement. Now, the lesions of the pupillomotor fibers. So, between the brainstem and the cavernous sinus, pupillomotor fibers are located superficially in the superior median quadrant of the nerve. They derive their blood supply from the five blood vessels. Surgical lesions such as the aneurysms, trauma, and characteristically, they involve the pupil compressing these vessels and superficially located these pupillary fibers. So 10% can have normal. And medical lesions such as diabetes and hypertension, they usually spare the pupil, but 30% can be involved. As the microangiopathy, diabetes and hypertension associated with these diseases involves this vasa nervosum, so causing the infarction of this main trunk, but spares the peripheral pupillary fibers. Now, the investigations for Turner palsy are blood sugar, BP, lipid profile, ESR to rule out vaginal cell arteritis, X-ray skull lateral view to rule out cellular lesions involving the cavernous sinus, MRI or MRA in complicated Turner palsies where other neural structures are involved. Isolated Turner palsies with no pupillary involvement, where the patient is over 50, MRI scanning and ischemic vascular evaluation and daily pupil evaluation is indicated. Lumbar puncture demonstrate the presence of blood in the cerebrospinal fluid and inflammatory reaction, neoplastic infiltration, or infection. Psychological examination of the CSF is used to diagnose meningeal carcinomatosis and lymphomas. Now, the cerebral angiography is the definitive test for Berry's aneurysm in all the intracranial locations. If the patient is under 50 with no pupillary involvement, intracranial angiography is indicated because ischemic vasculopathy, the medical causes are less likely in this group as compared to the aneurysm. So it can pick aneurysms more than 3 mm in the size. And in adult patients of any age presenting with complete or incomplete isolated Turner palsy, so it is a medical emergency and the patient have to go intracranial angiography immediately. In these cases, the likely cause is subarachnoid aneurysm and the patient may die if the aneurysm ruptures. And children under the age of 14 rarely have aneurysms. The majority of Turner palsies are traumatic or congenital. So if the pupil is involved, we do imaging to look for intracranial cause, MRI or MRA. If there is a surgical cause, then referral means any trauma, if any tumor, etc. So surgical cause referral. And if it's normal, then we'll do lumbar puncture. If the pupil is clear, then we investigate for the ischemic causes, diabetes mellitus, hypertension, CVA, and coronary artery disease. And if there is sparing, then also we still observe for 5 days if there is late pupil involvement. If it is involved, then imaging. And if it is not involved, then we check every 4 to 6 weeks. So mostly there is recovery at 6 weeks to 3 months. If there is no recovery, or if there is progression, or if there is aberrant regeneration, then we do the imaging. And in pupil sparing, less than to 50 years, or in children less than to 10 years, we do imaging. Surgical causes aberrant regeneration. A nerve that originally supplies one muscle may get connected to another muscle. In ischemic causes, there is no aberrant regeneration. It only occurs in the surgical causes. So if the nerve supplying the inferior vectors, they get connected to LPS. So when the eye look down, the eye retracts, which is pseudo-von Graffius sign. If the medial vectors fibers get connected to LPS, so when the eye ducts, it retracts. If the superior vectors get connected to MR, so when the eye looks up, it adducts. And if the ciliary ganglion fibers are connected to the sphincter muscle, it leads to sustained constriction on light. So to summarize, the oculomotor nerve is a motor nerve which is responsible for most of the eye movements, LPS and pupil constriction and accommodation. It has general rheumatic efferent, which is for eye muscles, general visceral efferent, which is for parasympathetic fibers for the pupil and the lens, and the general somatic afferent for proprioception. So the nuclear complex is located in the midbrain at the level of superior colliculus, and it includes the main motor nuclei and the Edinger-Westphal nucleus, which is the parasympathetic pathway. It connects with the cerebral cortex, superior colliculus, frontal eye field, pretectal nucleus, and other cranial nerve nuclei via the MLM. And it has four segments of fascicular, basilar, intracavernous, intraorbital, and it innervates the superior and inferior divisions. The ciliary ganglion is a parasympathetic ganglion with sensory root from the nasociliary nerve, parasympathetic from the Edinger-Westphal, and sympathetic root from the internal carotid plexus. It gives rise to the short ciliary nerves for ocular innervation, and in pathology, causes of palsy are diabetes, hypertension, trauma, aneurysms, tumors, and infections. Ptosis, the deviated eye is down and out, fixed dilated pupil diplopia, and loss of accommodation syndromes are Weber's, Benedict's, North-Nigel's, and Claude's. Angiography is critical in suspected aneurysmal third nerve palsies.